Hello, and welcome to this VetLit podcast. Have you ever diagnosed anaphylaxis retrospectively after the acute phase? You've volume resuscitated quite an unstable dog, and in hindsight, for one reason or another, you realize it was actually anaphylaxis. Maybe that was a big ALT elevation on your biochem. Maybe it was gallbladder wall edema you spotted afterwards. Maybe it was a colleague suggesting that it was anaphylaxis. But now you have a stable dog that was treated successfully without adrenaline or epinephrine, using supportive care only. My name is Simon Cook. I'm a criticalist here in the UK, and today we're tackling anaphylaxis and the role of adrenaline or epinephrine in the management of anaphylaxis. There was a fascinating study published recently on dogs with anaphylaxis being managed without epinephrine, and so we brought Dr. Ryan Smith, the supervising author on that study, here to discuss it. The study was from DACVECC and it was entitled Retrospective Evaluation of Outcomes in Canine Anaphylaxis Patients Receiving Late Epinephrine or No Epinephrine, and it was in 49 cases. Dr. Smith is an associate professor of ECC at Louisiana State University School of Veterinary Medicine. Dr. Smith, thank you very much for joining us.
Thanks, Simon. Thanks you for having me on and giving me the opportunity to speak about my most favorite subject in the world.
Excellent. Really cool to hear. I might make that full sort of switch to epinephrine now. I think that's going to be better received by the US audiences, isn't it? Rather than adrenaline. Now, with Dr. Smith's permission, I'm going to caveat this recording first. What we're not saying is go freely and withhold epinephrine from all of your dogs with anaphylaxis. That shouldn't, we don't think, be the take home. What we're discussing is the role it does have and the cases that Dr. Smith has experience with. So, Dr. Smith, Ryan, I might switch to Ryan as well. Could you tell us a bit about the run up to this study? You've published on the topic a few times. So, what brought you here?
Well, what brought us to this place, Simon, is sort of an ongoing realization that really two main things. Firstly, that we've seen a lot of anaphylaxis cases in our little part of geography, and many of these cases have tended to stabilize before ever seeing a dose of epinephrine at all. The times that we've used epinephrine leading up to this point have been fairly lackluster in, our collective anecdotal opinions. And so what really came to pass was several years ago, my colleagues and I sort of spoke about it and our individual experiences, how we were trained, what we've done in the past, and sort of reached the same conclusions independently that we weren't particularly impressed with the activity of epinephrine for these cases in dogs, at least. And a lot of those cases just never seemed to truly need it. And it sort of found its way naturally out of our typical protocol. I mean, we see a ton of these cases, right? So we figured at some point we've eliminated epinephrine essentially from our baseline protocols in treating these patients probably 5, 6, 7 years ago.
Okay.
Every once in a while, a case might see epinephrine, but generally speaking, few and far between. And there's really, running up to this, no explicit studies on the utility of epinephrine up to this point. Everything has been, even in our retrospective from 2020, has been just secondhand at best. So we wanted to say, you know what? Let us put together something that is descriptive. Since very few of our cases ever get epinephrine, they naturally don't get epinephrine. We don't really have a lot of selection bias here. So, let's see what we can do to describe what the outcomes are for these patients that have never seen epinephrine. How do they do compared to what's already published out there? And what we found, I think, is pretty interesting bit of information.
Absolutely. I totally agree. Do you think there's a case that anaphylaxis is one of these presentations that has remained uninterrogated for a while? We think we've got the recipe, you go with fluids, you go with adrenaline, and that's kind of case closed, and no one's really interrogated it for a while. Do you think that's the case?
I mean, I definitely think that that's a case, at least in veterinary medicine.
Mm,
If you look holistically at the data that's out there and what we use to put together our understanding, a significant chunk of this is actually straightforwardly derived from what's published in experimental models or human medicine. And it's just taken for gospel, largely attributing to the fact that I think it's nigh indisputable that epinephrine is the treatment of choice in humans.
sure.
But, but we have to understand that the pathophysiology, while there are many, many parallels, all the way down to the target organs and in some species, the primary mediators aren't exactly the same as what it is in humans or cats or cows, so on and so forth. So I think that we would be unjust to ourselves if we didn't, take the microscope and look at this a little bit deeper to say, hey, these parts of the pathophysiology, these parts of the pharmacology don't necessarily match up completely with what we're used to.
Okay.
Is this truly the case here? Question mark.
Excellent. Maybe it's a good point to draw a line. What do we actually mean by anaphylaxis? Because we should draw the line, even if it is blurred, between a simple allergic reaction, no matter how much of the skin is affected, for example, and a genuine anaphylaxis.
Sure. So by pure definition, anaphylaxis is going to be a hypersensitivity reaction that is multisystemic. It truly is as simple as that. So if you have more than one organ system involved, by definition, it is anaphylaxis. If you have your, run-of-the-mill post-vaccine puppy that comes by with a swollen face and vomited one time, technically by definition, that is anaphylaxis. Mild form, but nonetheless anaphylaxis. And like many things in critical care, it exists on a continuum, right? It's not binary. It's not yes, no, black, white. It's all a gray area. You've got the most mild of forms that may present just as we described that puppy, all the way down to your poster child of a
Hmm.
of an anaphylactic case, your 2 to 2.5 year old, and let's just say that it's going to be a pit bull or a pit bull mix. That's our poster child,
Okay.
and they come in flat, trying to die after being completely normal an hour ago, and it can be anywhere in between. And so, you do have to draw those lines, particularly if I had to pick one single place, it would be the line between what creates a severe anaphylactic case versus a, let's say, less than severe, so the mild to moderate cases. Why draw the line there? Well, simply put, the severe cases are the only population that are going to die from this. Everything else has a unanimous survival rate of 100%. So they're not going to die unless they're severe state.
Yeah. And so then you've got your specific 49 cases, they were characterized as having severe anaphylaxis based on there being marked cardiovascular instability and then two specific organ systems affected. And you've got GI, cardio, and resp. Is that the case?
Yes, it's definitely the case where the selection criteria were such that we did have to be very specific in screening because we wanted to select for those cases that were genuinely at risk. Targeting anything else was going to include a natural selection bias for survival, right? And so the criteria that we used were based upon um, severity grading scales that had been used and adapted previously, predominantly from the ones that we had used in our previous studies. But all of these really find their roots back into a combination of systems found in human medicine, one of which particularly was adapted into veterinary medicine by Anna Rostaher and her crew, who's actually a dermatologist out in Europe.
That's one of the things I wanted to ask you about actually, because the dermatological involvement wasn't a necessity for the inclusion, and I think I thought that was interesting, or at least just worth underlining, right? Because it's not always the case that those are even present, or if they're present, they can actually be quite mild, can't they? Sometimes you really have to squint to convince yourself and confirm that there's a classical dermatological component of the allergic evidence. Do you have the same impression?
I 100% agree with that, Simon. As a matter of fact, in the more recent studies that were published, including the one that we did in 2020, looking just broadly at the disease and how it presents, um, I usually teach the dermatologic findings as being the easy button because it turns out that maximally approximately 25% actually show up with any kind of dermatologic abnormalities whatsoever, and that can be as simple as just local or regional erythema, even. So you don't even have all the time the classical urticaria or angioedema that would come along with it.
Yeah, that's really cool. We were literally last weekend all crowded around this tiny little dachshund in full-blown anaphylaxis, and we were squinting at its muzzle trying to decide if there was a degree of angioedema there. And I think on balance we concluded that there was, but we had to look really hard to convince ourselves of that.
Yes, and I will say, just interesting point of conversation. This may be one area of medicine that we may be just a little bit ahead of human medicine in recognizing that anaphylaxis can show up in many different ways, involving any combination of systems and sometimes even just cardiovascular as the primary organ of dysfunction. And there are some bits of literature coming out now on the human side that are really starting to highlight these phenomena. And so it's really upending all of their classic definitions of what anaphylaxis is and how to describe it clinically.
Wow. Are we going to lead the way like we did with crystalloids?
Who knows?
Okay, I'd like to know what you think because it's my impression that we're getting better at diagnosing anaphylaxis. For example, with like I mentioned, the appreciation of the drastic ALT elevations, the gallbladder wall edema, the just increased awareness, and the hemabdomen findings that we're documenting on POCUS, and that maybe there is a case that some of these have flown under the radar as just being GI presentations with a surprising degree of cardiovascular instability that have done all right with fluids, and then we diagnose retrospectively. What do you think?
So I have a few thoughts on that actually. Firstly, I wouldn't even limit it to just that demographic. How many of these guys that show up with mild or moderate clinical states where they're decently compensated, is anaphylaxis even crossing our radar on these cases? Or are we just saying, oh, a bit of vomiting, some diarrhea, let's give you some subcu fluids, maybe some probiotics or whatever your choice treatment is for that, a dose of meropitant and send you out the door, and we were never the wiser. Um, I feel that happens much more often than we probably give ourselves credit. And to the credit of these cases, that's one of the amazing things about this disease that sort of, helped to prompt this study was, how many of them are just never recognized, never get these treatments, and do just fine. We might say that about many diseases in the veterinary world, right? But this is one in particular. And going back to your point about better recognition at this point, for better or worse, I do think that is a very huge part of the progress that we've made medically on anaphylaxis, at the very least in dogs. Cats are still a little bit of a conundrum,
Yeah,
but
totally.
but for dogs, absolutely. I look back 7, 8, 10 years ago. And I can genuinely, remember at least a handful of pretty prominent cases that I just flat out missed. And a lot of this came back to thinking back to my time when I was a student. I don't ever remember learning about it,
Yeah.
much less how it presents. Maybe we learned a bit about the respiratory signs in horses, but that was, to my remembrance, the best that we got. And here we are, several years later, and we're not even seeing a whole lot of referral cases for this now. Habitually in the past, say 10 years ago, we would get referrals quite frequently about one of my favorite diseases that was sort of a clinical mimic in the minds of our referrers was mushroom toxicity. They would get sent for mushroom toxicity because acute onset things, elevated ALT, right? And then they end up on our doorstep. We end up diagnosing anaphylaxis. Sick and palm toxicity was another big one. These are two things that are fairly common out here. And so they would get sent with the adage that this was an acute toxicity and this was the problem. And of course, these cases largely did just fine, most of them. So this information starts coming out. We start better describing the cases, publicizing things a bit better, giving some ideas on how to go about treating them, which you have to admit, in veterinary medicine, there have been significantly more discussions on anaphylaxis in dogs over the past 5 years, 7 years than ever before.
Yeah.
And we're seeing that recognition create a much better environment for the patients and for the clinicians. They can quite adequately treat many of these patients without ever hitting the referral button, right?
Yeah.
Which is fantastic for our patients, our clients, our clinicians. Maybe not so great for us doing the research on it,
Yeah.
but we'll take the win.
Yeah, and I also it's I'd way rather have the anaphylaxis diagnosis than the Amanita or the Sago palm diagnosis as well, right? So really,
Absolutely.
so ultimately you've gone one step further and said, well, there are these cases that slip the net or are diagnosed after the event, and asked the question, how often do they actually need the adrenaline and what can we describe? So what did you find in your 49 cases if I were to ask for your author's take home?
Sure. So, we when we were putting together this project, the idea was to just look at several different outcomes, not just survival per se, in order to determine just broadly based what was the profile of the subset of patients that just never had received epinephrine for their severe anaphylaxis. And ultimately, yeah, we found some here and there things like many such studies do, such as presenting temperature or lactate levels, shock index. The two major populations that tended to be different with those things were going to be survivors, non-survivors, for the shock index, and ultimately for lactate and temperature, whether or not they were more likely to actually need the pressors. But truth be told, I don't know how much stock I'd necessarily put in those things because the population of non-survivors was so small. We're talking about only 4 cases.
Yeah.
You really cannot make fantastic comparisons there. So I take those things with a bit more of a grain of salt. I look at the lactate and the shock index as, well, expected results, right? You expect that the more profoundly affected or the patients that were a bit more firmly set in their shock state were going to probably require a bit more work, maybe be at higher risk of having a worse outcome. So that all makes sense. I think the things that really stood out to us the most were looking at what the survival rate was in patients that hadn't received epinephrine, roughly 92%, which, we didn't make it, there were no comparisons to make here. It's just descriptive.
Hmm.
But if you look at what other studies, recent studies, have generated in terms of their survival rate, that is right on the money, really. It's pretty similar. Um, the lowest of the survival rates that have been pitched for anaphylaxis was our 2020 retrospective at 85%. And the best of the survival rates was out of Australia, Kate Turner in 2021 at 99.6%. The higher rates, though, what you have to read between the lines of these studies is that they weren't just the severe cases, right? They were all the anaphylaxis cases, so that naturally will push that survival rate up a bit. When you look at the ones that really only included the population subset that we were looking at here, the severe ones, the picture gets much closer to the 92%. Summers in 21 got 87.5%.
Okay.
Natsusko got 90.9%. So I mean, we're all right there. We're all right at that magic little 90-ish plus or minus a couple percent mark. And the difference is our guys, not a single one of them received early epinephrine.
Yeah.
All of the other studies, it was very hit and miss.
Yeah.
With the ranges of patients that had actually received the drug, anywhere between about 15.8% up to 59.7%, which I might add, the 59.7%, again, was our retrospective, which included the worst of the survival rates. Just saying.
But it's really cool though to pick up on you're really highlighting it with this study, but it's there if you go digging to see that actually not all of these dogs previously have received epinephrine. Great. So you're saying amongst those 49, none of them got and this is just for the readers, the listeners, but amongst those 49, none of them got the early epinephrine, but a handful of them were treated with a vasopressor of some sort later on in the disease process.
Yeah, so roughly 18% or about one case in five did receive pressors. And generally, our pressor of choice for these cases actually is norepinephrine. Um, the idea behind that is really just based on pharmacology, right? So in human medicine and in cats, um, we lean a bit more on the beta adrenergic properties that come with epinephrine, because in those species, the uh, the clinical signs associated with respiratory compromise, increased bronchosecretions, bronchoconstriction, those kind of things are significantly more piece of the clinical picture. But that really isn't the case in dogs. In dogs, the target organs lie elsewhere, predominantly in the abdomen, right? And so the benefit of having those beta properties, at least as far as the respiratory tract is concerned, are largely unnecessary. I won't say that there aren't some cases that would benefit from it. For example, I would probably be happy to give epinephrine to a patient that is anaphylactic and genuinely displaying signs of respiratory compromise. Because at the end of the day, the clinical signs that we see are largely going to be dependent on which vascular bed those mediators hit first, right? And so I'd be happy to give it in those cases because it makes sense pharmacologically. But in a majority of them, the respiratory signs that we see make up a vast minority of cases. And even those that display some signs, majority of those cases don't really end up being compromised. You may see, tachypnea at best and most prevalently. Most of them don't have genuine dyspnea, cyanosis, or anything remotely close to that. So the beta side of things doesn't make as much sense unless you're looking for the beta 1 properties with the cardiovascular system, which makes a little bit more sense. But in my hands, I haven't had the best of luck with epinephrine. I've put patients into ventricular tachycardia, even VFib, with epinephrine before, and it always makes me a little bit nervous to throw beta adrenergic response at a patient with a severely compromised cardiovascular system. It's like, adding a bit of added requirement of oxygen and energy substrates in a patient that is already significantly compromised. So the choice to move toward norepinephrine rather than epinephrine was mostly in a bid to try to avoid the beta effects and focus on those alpha effects, which really are more what we want in these cases. We want the cardiovascular, particularly the microvascular effects of norepinephrine, where we remove the natural vasodilation that comes at the hands of the pathophysiology of the histamines. We are hopefully able to mitigate the vascular gaping that causes the extravasation of fluids. And so it makes a lot more sense to me to focus on the alpha rather than the beta in dogs.
I love the physiology tour, and maybe for the listeners as well, we'll just do a little fly through. So we're saying that the epinephrine is gonna hit your beta one, primarily cardiac based, beta two, for argument's sake, bronchial predominantly, and then your alpha one, alpha two, all in pretty equal and pretty exaggerated extents. Whereas your noradrenaline, your norepinephrine is gonna hit a little bit of your beta one, not your beta two, but then get your peripheral vasoconstrictive effects via your alphas. Just as a mini tour for those that have not studied it as recently as yourself, Ryan. Do
Absolutely,
you,
I appreciate that.
the other question I wanted to ask was, do you have an idea? I think you do allude to it in the study, but for the listeners' benefit as well, do you have an idea of the number of animals that, in your whole study period, the same time over which you were collecting cases for this study, did get early epinephrine? You know, that somebody chose, but for whatever reason, to give the early epinephrine versus taking on your approach, which is broadly, as far as I can tell, go with volume and then add in a pressor later technique.
Sure. So for I guess for the sake of the listeners, just defining what early epinephrine means to us, when we were conceptualizing this particular study, we were looking at patients that had received epinephrine at any point within the first couple of hours of presentation. So pretty much a scenario where you would be presented with a patient, you would reach the presumed diagnosis of anaphylaxis and immediately think to give epinephrine. 2 hours seems reasonable to come to those conclusions for most cases, right? Maybe not all of them, but most. So we were looking at cases that had received either nothing at all or it was outside of that 2 hour range. We only included one case that had received epinephrine at literally any time. And, full disclosure, that patient was disastrous for more than one reason. This patient actually ended up bleeding out on us and dying at the hands of a left lobe hepatic rupture. And that patient, we were having such a devil of a time stabilizing. We were throwing everything and the kitchen sink at this patient to try and stabilize to no significant avail. If we look beyond the study population, I want to say we excluded 3 total cases for having received epinephrine within that time period.
Okay.
2 of the 3 were given epinephrine prior to referral. The third was the discretion of one of our clinicians direct cause undetermined. Outside of that, we really haven't seen significant epinephrine use since we published the 2020 study, which had probably the highest prevalence of it. And even then, the reasoning and the rhyme behind it was a little bit more challenging because, quite frankly, many of those cases had occurred either before or shortly after myself and my colleague, Dr. Verlo, came on board and started looking at things.
Very cool. Okay. I noticed that there was a reasonable number, 14 dogs received plasma products. Is that an interesting observation into the way you practice there? And is that, for example, something that you reach to before somebody else might reach for epinephrine?
Quite possibly. I honestly don't know that there are many, if any, other institutions that are treating this the way that we are necessarily. And to that note, when are we pulling out the plasma? I have historically gone on record and saying that here we are quite aggressive with pulling out plasma as long as our owners are financially able to do it. Uh, Somewhat anecdotally, we have tended to find that when we pull out the plasma fairly quickly, even some of the more challenging cases to stabilize tend to stabilize fairly quickly after a single dose. And, there's a few reasons why that might be. I mean, things that have been proven that we do know that anaphylaxis seriously impacts the patient's hemostatic capabilities progressively more with the severity of the disease state. But, to what degree is that clinical? Still a question mark unless we're talking about those hemoabdomen cases, right? The hemoabdomen cases are not uncommon, especially when you have the severe patient population. And with some of our findings so far, we've had one case report, and we've got a study ongoing right now to try to root out why that's happening. But I can tell you that I have approximately a handful of necropsy reports now that have demonstrated these patients having some degree of hepatic rupture. And so, sort of one of the centerpieces to why we've transitioned to resuscitating these patients the way that we do actually is based on a hybrid concept of traditional resuscitation with some of the tenets of low volume resuscitation that we would find in a trauma or a hemorrhage patient, especially if we identify a patient with anaphylactic hemoabdomen, based on these cases that we've had that have done so poorly uh, with um, with hemorrhage. So we've tended to sort of adopt a hybrid approach there, where we will focus first on making sure that the cardiovascular system is resuscitated well enough, has enough fluid in the pipes, if you will, in order to make any of our other efforts, such as the need for pressors or whatever, a lot more worthwhile and effective. Because at the end of the day, I mean, I can't speak to anyone else's experiences, but with mine, these patients commonly come in with a PCV in the high 60s, 70s. I think my personal best is 81%. And, you can throw pressors at that all day long. It's only going to do so much because there's no fluid, right? It's all being extravasated or lost into the GI tract or where have you. And so our first focus has tended to be volume resuscitate them to a PCV of less than 60, and then we've got something to work with. Then we'll start on pressors if we need, and we'll usually be very quick to institute plasma if there is any serious concern for coagulation derangement or straightforwardly the presence of a hemoabdomen.
Yeah.
We'll bring that out very quickly in the process. when we were writing this study and getting it through peer review, I knew it was going to come up as a question as to how these patients were being treated. And lo and behold, it did. With the first revision, it was a question on how these patients were treated. How do you decide what gets which treatment when? And rather than trying to toil and hopelessly explain this in words, what we did is we actually just tossed in as a supplement the algorithm that we use in order to sort of make these determinations to clear up exactly what it was that we were doing. And hopefully that figure gains a little bit of traction towards understanding how it is that we're approaching these patients right now.
Yeah, really cool. Really, really enjoy these thought processes. I've got a couple of just purely exploratory questions because you love the topic so much, and I flipping love how physiologically these are such cool cases to explore, also from a teaching perspective. Discussing the reason that a patient with anaphylaxis is unstable is endless food for thought in a small group teaching session I find with our students. I love it. So maybe I can give you the floor and just tell me if you would, why is a patient with anaphylaxis, real anaphylaxis, severe anaphylaxis, proper anaphylaxis, why is that patient so unstable? Give it everything in extremis. Why is it so unstable?
Oh, such a fun question, and every
Isn't it?
patient can be a bit different, right?
Yes. Yeah, yeah, yeah.
So anaphylaxis has given me teaching fodder that can go back all the way to teaching even basic concepts and tenets of shock in our veterinary school curriculum. It's one of my favorite things to teach. We are programmed into categorizing everything, right?
Mm.
And depending on which reference or resource you look at, anaphylactic shock is kind of its own group. I don't look at it that way. I subscribe to the shock classifications that are well outlined in our critical care Bible, the Small Animal Critical Care Medicine textbook. And one of my favorite pieces to sort of get a little tricky with the students is to have them tell me which type of shock, what category of shock uh, this patient is in or that patient is in. I'll usually make something up on the spot. And anaphylaxis is one of the ones that I love to hit on because they'll say distributive, and I'll say, sure, what else? And at that point, they say, wait, I don't, I don't understand. It's like, okay, well, let's talk about this, right? So anaphylaxis, how does it work? We'll focus in on the dog because that's the easy one,
Yeah.
right?
Yes, please. Yeah.
At least for me, it's the easy one. So anaphylaxis occurs. Shock organ in the dog is the liver. What is happening to the cardiovascular system here? Well, it does two different things in two different vascular beds. Arterial vascular bed is going to dilate, right? And the venous vascular bed, particularly large vessels like the hepatic venous sphincter, actually is going to have the opposite reaction. It's going to constrict. What does that cause? You've got significantly more hepatic blood inflow, significantly less outflow. What happens to that blood? It pools, it backs up all throughout the portal and splanchnic vasculature, which causes what? Well, if we think about perfusion, what is perfusion? Perfusion in any given tissue is going to be the difference in, pressures. What is the arterial pressure subtracted by the greatest force acting against it? In this case, and many other cases, it's what is the venous pressure? That venous pressure goes way up. Your arterial pressure already going down because your cardiac output is trash. You are going to have significantly worse perfusion throughout all the abdominal organs. GI tract does not like that at all, right? You will start sloughing your GI mucosa, losing a lot of fluid there. All the while, all of this blood that's pooling makes up about 35% of your total cardiac output. So effectively think of that volume as lost volume that's not making it back into circulation. Well, of course, that's going to cause a significant and very rapid dropout in cardiac output, right? So, what's your second type of shock? Hypovolemia. And you can maybe even make a an argument that there's a little bit of an obstructive component there because of what's happening at the hepatic venous sphincter. So I let them have fun with it, but it's one of my best and most useful types of cases to teach them this idea that no one said you can only have one type of shock. And in actuality, in a majority of the cases that we tend to see, there's not just a single type of shock that's present. And this can even go towards, um, sepsis or even heart failure. Left-sided heart failure with a patient that's blue and struggling to breathe. There's more than one type of shock there. So that's
Absolutely.
sort of how I present it usually.
Oh, 100%. I totally agree. And you can make a septic peritonitis fits quite well into these as well. You can give them every single you can give them whatever type of shock you want. It's really cool physiology to
Absolutely.
explore. And then you chuck in, I agree as well. I've got some, I mean, this is anecdotal, but some descriptions of a grossly ruptured liver in a post-anaphylaxis cases. So we're making the case that as well as them being hypocoagulable and the clinical relevance of that, as you say, yet to be determined, there's a reasonable case by the sounds of it that these livers are literally rupturing through those elevated pressures due to the histamine-induced venoconstriction, which is really quite remarkable, isn't it?
It is, and I mean, there certainly are several potentially viable mechanisms for which that can be there. Of course, we do have some cases that have explicitly demonstrated hepatic rupture. Well, why is that there? Uh, Two main reasons that I can think of that this might occur. Reason number one, with such rapid volume expansion in the hepatic parenchyma, you think about what happens if you blow up a balloon too fast. Pops, right? Or it can pop. So, sure, maybe that happens in some of these cases, but what is the most common history or one of the most common historical elements that we get out of these patients? They go outside, they come inside, they're lethargic, and they collapse, right? Well, maybe this very engorged, now friable liver uh, takes a nice, sturdy little traumatic hit, something that would be very innocuous to a normal patient. But for this patient, maybe that's just enough to cause that little, focal rupture, and then we're off to the races.
Yeah. Wow.
Could it be that the hemoabdomen is there because of weeping or because of the inherent coagulopathic derangements? Could it be any and all of these or different between each patient? I think this is all still on the table.
Yeah.
So, that's certainly one thing that I'd like to have figured out before the end of my career as well.
Yeah. Very cool. One of the other sort of observations I had in doing some background reading here, and I forget which study, if I'm completely honest, you'll probably correct me here, but there was one of the previous case series was describing the physical examination findings in these dogs and saying that on inspection, they often had a peripherally vasoconstricted phenotype appearance. And, maybe that goes against what we're saying that they have this massively distributive component. At least my theories behind that is to say that actually, well, it's not necessarily that you've just got peripheral vasodilation. As you say, so much of that blood has been sequestered in the hepatic parenchyma and lost into the GI tract, lost into the peritoneal space. And then we're not saying that these patients don't have any adrenergic reserve of their own, right? So they're pretty, I don't see why they're not pretty capable of chucking a whole load of that out and creating mucous membranes that are pale and with a slow CRT rather than what people, I think, when they read a book, might expect to find with regards a vasodilatory appearance.
Mhm.
What do you think about that?
Yeah, so I think we need to get into the habit of considering it a complex process because we do truly have indicators of both things occurring. And I think the study that you're thinking of was Kate Turner's study out of Australia in 2021.
Yeah,
And I definitely took notice of their findings as well to this point, because I don't think that we can argue that there is a distributive component here. We do see the vasodilation on the arterial side, which contributes to the drop in cardiac output. We also see the significant extravasation of fluids that leads us into having a PCV in the 60s or 70s or 80s, right? So that component is definitely there. But for certain, most of these patients showing up with that vasoconstricted pathology and seemingly the attempted compensation very much exists, right? It can't be ignored, and it seemed to be more prominent than any other form in that study. So I don't think that we can necessarily just look at the pathophysiology of anaphylaxis as being that strictly black and white, and when it's
yeah,
inherently such a complex and mixed process.
yeah. I love it. I'm not, just to be clear, I'm not challenging anyone's findings there, but I do just love the number of ways in which you can interpret these patients and you can think through their physiology. I find it really, really stimulating.
Oh, I don't think you're being contrarian at all. As a matter of fact, I had this very conversation with Dr. Turner one time, and
Ah,
it's kind of amazing how similar the thought processes are amongst different individuals when it all comes down to it. We I think we all tend to have very similar experiences at the end of the day.
cool. So then my one final wrap-up question is, how has this study been received by the community, by your colleagues and the ECC community in general?
I feel surprisingly well received, actually. I mean, for one, I've gotten the opportunity to speak on this topic within a capacity that I really didn't think that we would get to be talking about quite so soon.
Excellent.
Um, Generally, I think that the feedback that's been received so far has been, to some extent, a bit of validation for some. There's certainly a subset of individuals who share our feelings and relative disengagement with the use of epinephrine. But at the same time, it I think this study really opens the door to be able to justify dealer's choice on whether or not you prefer to give epinephrine. I don't think that there's anything wrong with giving epinephrine. There's a lot of reasons that have been validated in studies that do make a lot of sense. But for those who maybe are less apt to do so, um, I think that there's grounds to feel that way, and something now that you can point back to, and really just hold firm on that position. So dealer's choice at the end of the day as to whether or not you choose to give epinephrine. What I'd really like to see, eventually in the near future, is a genuine prospective trial that looks at whether or not the use of epinephrine or norepinephrine, given in tandem with volume resuscitation, actually optimizes stabilization and total volume load that is given to these patients. That's the next really big piece that I would like to see come out of this discussion.
Really cool. Very cool wrap up. Thank you very much. Ryan, it's been a really amazing discussion. Thank you so much for answering my questions and indulging me and enjoying it as much as I did. As always, the aim of VetLit is to make veterinary literature not just more accessible, but actually accessed. And I hope we've managed that in some small way in this episode. If you found this useful, a quick star rating wherever you listen really helps get the conversations to people who might benefit from them. You'll almost definitely find something that interests you on the vetlit.org site, so do have a browse and you can check back here, there, or via the email updates for more. But for now, have a great day. It's goodbye from Dr. Smith,
Thank you for having me. It's been a pleasure.
and it's bye from me. Bye bye for now.